and decision-making process regarding elective procedures. After they give a few brief remarks, we will take your questions. Dr. Snyder.
As our testing and that of others has revealed, COVID-19 is here in our region. Across the UPMC system, 28 symptomatic patients have tested positive, with 4 of those people currently hospitalized. UPMC has over 5,500 hospital beds set up and staffed, including 750 ICU beds. Thus far, the COVID-19 cases have had a minimum impact on patient care at our facilities. However, the future remains uncertain, and we are monitoring activity continually. The vast majority of these positives were identified using our own unique testing ability, with additional specimens tested at the State Department of Health. Our testing efforts are off to a strong start, and we are building capacity quickly. We are now able to test 80 specimens a day through our central lab and expect that to double by next week. Our turnaround time has been within 1 calendar day, with most patients getting results run by our lab in 8 to 12 hours. As commercial labs ramp up their own capabilities in this region, which we fully intend to use, having our own test has given us a head start on better caring for our patients and protecting staff. Test results for UPMC patients are shared via electronic medical record with their physicians to ensure a seamless coordination of care. Our new specimen collection center on the south side is operating smoothly and safely and has been well received by our patients and clinicians. This facility is operating with the highest standards of safety for our staff, our patients, and the local community. Our dedicated and well-trained staff at the Southside facility have shown that what we are doing can be safely reproduced in other locations, and we expect to add facilities starting early next week throughout our system in Williamsport, Harrisburg, Erie, and Altoona. We will also continue to consider open-air facilities when that becomes appropriate. Setting up our own specimen collection and testing capabilities has been an extraordinary multidisciplinary effort, involving doctors, nurses, lab workers, infection control, supply chain, and many others. We want to thank this incredible team for making this testing available to help ease the anxiety of our patients, and most importantly, to ensure that we're providing effective and safe care. Now, Dr. Williams will tell you the latest about his efforts to monitor the presence of the virus in our region.
As we discussed with you last week, we continue to test de-identified research surveillance samples of adults and kids with cold symptoms from our region. These were collected in outpatient clinics, the emergency department, or the hospital to track the spread of the virus in our region. This testing can't be used to diagnose individual patients. So far, we've tested nearly 950 samples, including 350 from children. 5 adults collected from outpatient clinics or the ED have tested positive, and no children have been positive. This means that we're not seeing widespread community transmission yet, and there's no evidence that Pittsburgh is becoming a center or a cluster of activity like we've seen in so many other cities. But that doesn't mean anyone should let down that guard. The virus is readily transmitted, and it's still an important public health threat. It's still very important to maintain the social distancing and take other measures to protect the most vulnerable of our citizens. In fact, the lack of widespread activity means this is the best time to keep up the social distancing that we're practicing to have the greatest impact on the spread and to flatten the curve of the pandemic. By taking these steps, we can still mitigate the impact of this virus on our region and maintain our ability to care for those who may become critically ill. And I just want to acknowledge my lab team who's been doing this work. Moni Johnson, Amy Kinsler, and Sarah Walters have been working tirelessly for the public health of the Pittsburgh region. Dr. Yealy?
Thank you very much. At UPMC, we safely serve those who seek our care, including during this time when the pandemic is evolving. We are continually gauging the current conditions, and those are the conditions nationally and internationally, but more importantly, the conditions right here in Western Pennsylvania, Allegheny County, and Pittsburgh. We also gauge the needs of our patients and assessments about predictions on future demands on our healthcare system. We are and we will rapidly adjust our services and our plans based on the science and the facts. UPMC is completely aligned with the CMS and other governmental recommendations as we make those plans about care. We are not yet broadly canceling care. You've heard that elective cases and care are under restriction now. Elective cases and care is a very broad and it's an indistinct term. Many scheduled care opportunities, often called elective, whether that be cancer care, valve replacement in the heart, or hernia repair, address important health care needs that can't always be safely delayed. We rely at UPMC on the expertise of our world-class clinicians who, together with their patients, determine which care can be delayed without harm. Our goal is to keep vulnerable patients as safe as possible. We are continually monitoring COVID cases, both test-proven and suspected, in our facilities and in the regions. Fortunately, right now, both remain low. We have the staffing and the bed availability to provide the necessary care. It's one of the benefits of having a very large healthcare system. We are rapidly expanding our telemedicine capabilities across the system. That allows for distant care. That allows for unscheduled care, primary care, some cancer care, even some long-term care and other needs. In one day this week, we delivered the same number of telemedicine visits as we had in the previous 6 months combined. Pittsburgh and Western Pennsylvania are at the beginning of the experience with this pandemic, and we are closely monitoring the situation. The success of all the mitigation efforts will dictate how it is we respond in the future and when and if we need to change our strategy. UPMC is ready now, and it will be ready in the future to protect our patients, our staff, and our communities.
Thank you, doctors. And now we'll take a few questions from the media present here and those joining us online from across Pennsylvania, Maryland, New York, and Ohio. For those of you here, please step up to the microphones in the aisle, state your name, identify yourself and your organization, and I will attempt to intersperse some questions from our online audience between your questioning. And let's first start with Paul Van Osdale.
Paul Van Osdale from WTA. Dr. Yaley, as you know, the governor and the health department have ordered that all elective procedures be curtailed. It sounds like they're, can you better define what is an elective procedure so patients at home can understand what they should and should not be expecting to have done?
Thanks very much for that question, and I think you hit the nail on the head about the ambiguity here. Elective commonly means scheduled cases, but scheduled does not mean unnecessary, and the governor and CMS did not request that necessary care be canceled. We're trying to smartly identify, together with the physicians and the patients, what care can safely be put off that is truly on the lower end of elective care. There isn't any particular proclamation that defines that. We think the conditions locally around care and around COVID-19, together with the individual physician experts, the guidelines that we've created at UPMC, and their patients are the best place to make that. If you have a question, if you're a patient and have a question, pick up the phone and call your physician. That's where the conversation begins, and that's where the best decisions will be made.
Okay. In the back.
Hi, Sarah Bowden with WESA News. I can appreciate that deciding what elective surgeries to go forward with is a difficult process. However, I've spoken with a number of sources that say that a number of elective surgeries in UPMC have gone forward, and this is a poor choice because it uses personal protective equipment and puts staff and other patients at risk, especially when the patient has to be intubated. So I guess, what do you say to staff who feel that they're being put at risk when it comes to unnecessary elective surgeries?
Well, our goal is to make sure that we meet the needs of our patients and that we keep our staff safe while that's happening. We have adequate protective equipment for all types of care. We screen for people who may have the COVID infection, and we carefully created guidelines to help guide individual physicians and their patients about how to change care plans. We've had lots of cases already that have been deferred or canceled. And so, in fact, the perception that nothing has changed at all is inaccurate. Patients and physicians together have already made a great many changes.
Well, the issue with screening, though, is that patients often don't present with symptoms very early in the infection.
And it's exactly right that patients don't always have symptoms. It's why we use protective equipment all the time, even before COVID-19. We have that equipment available. We have equipment available for the future, and we're titrating back based on the facts as they exist here in Western Pennsylvania and predictions about the future.
All right, thank you. Sean?
Dr. Yealy, you can correct me if I'm wrong, but I believe you're still behind virtually every other hospital system here in Western PA. I think everybody else has moved further than you. Also, and correct me on that point, but also, can you tell me how many of your staff have either self-isolated because of possible exposure or been told to quarantine by the hospital because of possible exposure in the last month?
I'll take the second question first. I don't have the accurate numbers right now about how many staff total have been in some sort of behavioral change because of exposure or symptoms. It's an ongoing process as we're speaking. I suspect it'll change. You framed it as UPMC is behind other hospitals. I actually think UPMC is ahead of other hospitals. First and foremost, almost all other facilities, while declaring that there's cancellation, are using a very similar process, identifying care that's necessary and scheduled, in other words, the term elective, and providing that. Secondly, we think that the primacy of our mission and the governmental mandates is to make those decisions together. So I would not characterize the response as behind. I would characterize it as completely aligned with all good public health policy and serving the patients, particularly here in Western Pennsylvania, well.
You do have employees, many employees, who have been told to self-isolate because of possible exposure, correct?
Sean, I'll help address that question. First, we follow public health guidance on identifying potential contacts of COVID-19 infected patients, whether that be patients or whether that be healthcare workers. Additionally, as a hospital epidemiologist for the system, I have no interest in having a healthcare worker being exposed to COVID-19, and I have no interest in not helping a healthcare worker recover if they're sick or exposed and doing the right thing to keep their friends and their families safe. And so we have applied those public health guidelines. If a healthcare worker is exposed, either in the community setting or in the healthcare setting, to give them the right guidance to keep them well and to make sure we prevent transmission in our hospital.
But what Sarah's talking about is the same thing that I've heard, many reporters here in Pittsburgh have heard. We're hearing from your staff members. They're writing us and calling us, and they're posting stories on social media about their fear that they're being told that they're still having to show up and participate in elective surgeries. They've told all of us stories about staff being sent home because a patient was suspected of COVID-19 after the elective surgery.
They don't feel safe.
We've heard that repeated. I don't mean one or two cases. I'm talking dozens in the last 2 weeks. Have you not heard these stories?
We do a lot to help educate our healthcare workers about what we're doing to keep them safe and the precautions that we use to identify both healthcare workers and patients who might be infected with COVID-19 and prevent transmission. Part of what you've gotten to, Sarah, is about the asymptomatic risk. We have a lot to learn in the scientific community about what risk asymptomatic transmission represents. And truthfully, from an infection prevention standpoint, it's going to be very, very difficult to identify asymptomatic carriers. As a country, we don't have the resources to test everybody in the country for COVID-19 disease. And so we have to rely on identifying people who were, one, exposed to another individual with COVID-19 and give them the appropriate guidance before they become ill to prevent transmission. Two, continue to identify people who have traveled to areas where there's a high risk of transmission and give them the anticipatory guidance to avoid contact while monitoring for disease. And three, test aggressively, which is what we're doing now for both patients and healthcare workers.
But doesn't it make sense to have more austere measures since we do know that community spread is happening with Dr. Williams' sampling?
What Dr. Williams shared with us actually should be, in some sense, reassuring. So epidemics are not a homogeneous front. Epidemics are not suddenly we're awash with COVID-19 and it's everywhere. They're fluid, they're dynamic. There are areas of calm and areas of turbulence. This data is incredibly valuable to us to know that this is not northern Italy. We are not Wuhan right now. In Pittsburgh, this is an area of relative calm compared to where outbreaks are happening. And so that should give us a little bit of a measure of the risk and response that we need to take. So put differently, our job is to take care of patients, not to put them at risk, but to take care of patients and keep our healthcare workers safe when we do that. So taking the level of risk in our community, we have to balance that with still providing care. So as Don was talking about, we shouldn't stop providing care if we think we can do that safely. And John's data gives us a lot of sense about whether or not we can do that safely, and we'll continue to do so.
John, for Dr. Williams, I have a question from WPXI-TV in Altoona. For people who don't understand how serious this is and think the virus is being blown out of proportion, can you tell us how serious this virus is and how widespread it is?
Well, it's a great question because I think everybody in science, medicine, the media, and ordinary citizens has a feeling that there's a spectrum from it's no big deal to, it's the end of the world. We really have a lot of data now for the severity of illness from China, from Italy, from other European countries. And clearly it can cause severe disease and death in older adults, especially over 70 and 80. And it causes more severe disease and death in those with compromising conditions like diabetes, immune compromise, emphysema, heart disease. It can cause severe disease in otherwise healthy young adults, but most of those young adults are not all that sick and they're not ending up in the ICU, and they have much lower rates of death. And in children, fortunately, as a parent and pediatrician, while some kids are going to have more significant symptoms, fewer than 5% into the hospital, and there are really almost no deaths in the world attributed to the virus. So it matters a lot, the age and the underlying condition of the patient. So the reason for the social distancing is not because we're all going to drop dead of the virus. The reason is we have a lot of citizens. We all have loved ones who are older, who have these high-risk conditions, and we're protecting them. And I think the surveillance data says that it's not circulating widely. That was 5 positive adults who were outpatients out of nearly 700 adults tested. And so for these procedures that are also important for people's health, as Dr. Yili said, we can safely manage those procedures to provide the care we need to.
Thank you. The next question comes from Paul Goff of the Pittsburgh Business Times. Can you tell me the status of adding hospital beds, alternate locations for health care, particularly COVID-19 care, for the system in Pittsburgh and around the Commonwealth?
So UPMC has a comprehensive plan to begin by using all the current beds that are available as optimally as possible. So activate beds within facilities, make sure that decision-making with both COVID-19 patients and all other patients is as appropriate as possible, that staffing and equipment are available. And given the fact that we're a 40-hospital system, it gives us a lot of flexibility. Secondly, we do have the opportunity to use facilities that had recently been deployed as patient care facilities but are no longer, or other alternative care sites. And we've evaluated and created a contingency plan for that. That would easily give us another 25 to 40% more capacity. Finally, some novel ideas about new, particularly lower acuity care sites are a possibility should even more care demands come in a very short period of time. I'm sure most of you are familiar with that, tents or other particular opportunities. I don't see that being particularly likely, but we've begun to think through how could we add even more capacity if it's needed here in Western Pennsylvania.
Thank you. Go ahead.
Jamie Martinez with the Tribune Review. Building off of that question, can you put that into real numbers that people can understand? To say 25% of capacity, what does that mean in terms of number of patients? And can you also address supplies, things like ventilators and personal protective equipment for staff, what does UPMC stores of those supplies look like? We've heard stories of ventilators and other supplies going short in other places. So can you address that in terms of real numbers?
So I think everyone preparing anywhere in the country wants to have more beds, more equipment, and more personal protective equipment, period. UPMC has the benefit of, A, being a very large system, so 40 care sites, over 5,500 beds just today, roughly 750 beds that could serve as intensive care beds right today, and the ability to ramp that up by another 25 to 40% depending on the level of need. UPMC has more than an adequate supply of ventilators. You asked about that. Everyone wishes they had more in case the peak demand comes. Like many other places, we are exploring all the opportunities available for that, and the government has actually begun to be involved in that particular opportunity.
Okay, thank you. For a question from WPXI-TV, this is probably for Dr. Snyder. Would you address concerns from people who say they have all the symptoms but are being turned away from testing?
So we, like healthcare systems around the country, have had to adapt to the changing circumstances of the epidemic. One of the characteristics early in the epidemic has been a shortage of testing opportunities, testing capabilities, and additionally specimen collection capabilities. We have adapted as quickly as we could to stay ahead of the epidemic by first marshaling all the resources we could, two, making sure that we have additional specimen collection and testing capabilities, which we've talked about earlier in this conference, and accordingly have adapted from testing patients who are most likely to have COVID-19 to this week we have the opportunity to be able to adapt to test essentially any patient for whom a clinician is concerned has COVID-19. Mm-hmm. We have the capability to test, and we're doing that.
Thank you.
A question about medical staff testing. How often are you testing staff for COVID-19, especially because it can be asymptomatic early in the infection?
So we are following public health guidance on when to test. Public health guidance does not say to test asymptomatic individuals, so we're not testing asymptomatic individuals. And I'll say that there is another issue that's at play here, which is supply shortages. You've probably heard there's a lot of issues around the country and the world about supply shortages, and some of them are the mundane things that you may not think about, like the Q-tip-like swab that you have to use to sample a patient's nasopharynx to test, or the vials with the media that you need to do the testing. So those shortages are a potential threat to testing opportunities and are just one of the reasons why we don't test asymptomatic people. Additionally, I would say that for healthcare workers, we have said what we've always said to our healthcare workers, that please don't come to work sick. If you are sick, we have resources available to you to assess your illness. Our employee health service is excellent and has worked with healthcare workers to assess whether or not they're at risk for COVID-19 and to provide testing accordingly. And just like we are with patients, that testing is adapting as the epidemic is adapting, and currently have a very aggressive approach to testing.
Okay. Paul?
As you may know, the CDC recently released a guideline for face masks, suggesting that if necessary, face masks could be reused, and even in desperate situation, bandanas would be an acceptable alternative. I just wanted to get your opinion on that, what you all think of that, and is that something that you're going to be seeing here at UPMC anytime soon, based on the supply chain that you have?
Yeah, and I'll say with a tremendous amount of heartfelt sympathy for colleagues around the country and around the world that some areas are seeing the effects of some of these shortages and having to take drastic and dramatic measures when PPE shortages happen. We have adequate PPE for the needs of our communities at UPMC today, and we're working hard to make sure that that continues to be the case. We are anticipating and preparing for a time when that is not the case, and accordingly we have started to set out criteria for when we may take those CDC criteria and adapt our PPE model, our personal protective equipment model, and do so in a way that minimizes the risk to healthcare workers. In other words, if we have a patient that represents a less or minimal risk of transmission, that may be the place where we first use some of those CDC recommendations about alternative strategies. But right now, we are able to provide the PPE that is appropriate for all of the care settings that we're in.
And if I can add to that, we're beginning right now to make sure that we deploy this very important protective equipment smartly so that we do not go through equipment when it's not optimally protective. It would be very easy when given direction about the appropriate level of equipment to use, because it's not all the same for every type of interaction. It would be very easy to interpret that as, aha, there's not enough. That isn't the reality. The reality is we want to be smart about this on day one, and that's what we're trying to do here right now, so that there isn't a problem. We're not having this conversation in 2 weeks or 2 months.
Over here.
Chris Hoffman, KDKA. Will we reach a point with testing that anyone can get tested, whether they're showing symptoms or meet whatever check boxes, or will we continue to see it has to be certain criteria for anyone to get tested?
Is that a question or is that a statement?
Yes. Yes. Are we going to reach a point where there's enough tests that anyone can get tested, whether you have the symptoms or not? If I'm just worried, can I go get tested? Will we reach that number of tests at some point?
It's hard to predict because part of that, as I alluded to before, is related to supply chain. So it's not just a matter of are we willing to test everybody, it's do we have the resources to test everybody. Right now, we are testing everybody for whom we have a suspicion about COVID-19. In other words, we have availed ourselves of the new resources really this week where specimen collection and testing capabilities have increased. We seek to further expand the specimen collection and testing capabilities, as I talked about earlier in the press conference, to make sure that if a physician feels their patient needs to be tested, if a healthcare worker approaches employee health and is concerned that they may have COVID-19, that unavailability of testing is not a barrier.
Dr. Yealy,
Sean.
I'm sorry. You're taking part in this collaborative with the 6 other healthcare systems around here. You're talking every other day with other CMOs. Can you tell me about your participation in that, what you're finding in common with other facilities, and how you think ultimately that collaboration and those conversations might impact where we're headed with COVID-19?
Well, we've had open communication primarily by a telephone, and we've had the opportunity to share where each individual, either hospital or healthcare system, is at, what the potential threats or concerns are, many of which we've just discussed here right now, and what avenues of further collaboration or very specific contact might we be able to do. For example, today one of the conversations is what happens when critical care beds become more in demand? How between all of our systems could we manage things better? I'm encouraged by the activities. UPMC is not only a world-class institution, but we're the leader in this area, and it's incumbent upon us to participate fully and help lead those activities across the entire region.
Okay. We have a number of similar questions from Michelle Ganassi at the Somerset Daily American, Bill Kibler at the Altoona Mirror, the Cumberland Times News, and so on. It's basically the question is, how will UPMC's COVID-19 preparation impact patients at UPMC Western Maryland, UPMC Altoona, UPMC Harrisburg, any of those?
I think it'll affect them the same way it does here now, where we have plans to deal with any growth in demand from COVID patients, also to take care of the current patients and the future patients who might need, and have a clear set of alternatives to ratchet up to make sure that the capabilities meet those demands. Each individual region or site may have some specific nuances about that, but I'd expect as part of our large academic system, they'll be able to benefit from all of those same opportunities that a site here in Western Pennsylvania would be able to.
Okay. Jamie?
You gave us some numbers earlier about the total number of tests, but can you explain if that is enough of a sample size to draw conclusions about what's going on in our region, and just, how does that compare to the total population? Do we need to test more people to draw, better conclusions?
Yeah, that's a great question about the surveillance research testing, how representative a sample it is. So these are research and surveillance samples that are collected in outpatient clinics and emergency departments and all over our region and in several different UPMC hospitals, 4 or 5 different hospitals. So it's a fairly representative sample of the region. It's not just one clinic or one ER or one hospital. We've been doing this testing for a couple of weeks, and those numbers I gave you today are up through this week, so it's very current. So we think it's the best way to have a finger on the pulse of how much the virus is circulating in our region. These aren't selected patients because these are research and surveillance samples, so we're not targeting people who we know have traveled to high-risk regions. That's part of what determines the clinical testing that Dr. Snyder talked about. If patients have specific known risk factors of travel or exposure. But we do think this is a good representative picture of what's happening in our region. And although we know there are patients here with the virus, so we can't say it's not here, it really does reassure us that, at least right now, we're not seeing wide circulation in lots of patients who lack those risk factors.
Okay. Sarah?
Yeah, can you talk a little bit more about like how often people are added to this pool that you're sampling? How, like, I'm assuming that you're going to keep doing it, so how greatly does the pool grow, and how often do you analyze it?
Yeah, so the way these samples are collected is in several CDC-funded research networks that have been ongoing since before the COVID epidemic. And those are samples that are collected in outpatient clinics and emergency departments and hospitals. And we've been doing that since last fall as part of influenza surveillance. So we're getting those samples every day, going back, throughout the winter. The other group of samples are de-identified samples. These are samples that are collected in clinical care sites and have all identification stripped off. So we don't know the individual that it came from. This is part of why we can't use the test to diagnose individual patients. And those are being collected every day, so we're getting those samples on a daily basis from the ERs that we're collecting them from. So we think it's fairly representative, and they're very current samples, and we plan to continue doing this testing.
Because the samples are de-identified, then are there like 5 people in our community who have COVID-19 and they don't know?
That's a good question. So these samples, some of the ones that are collected in research testing, there is a mechanism through the health department to potentially trace those contacts. For those that are completely identified, you're right. There's no way to know that. However, what we can say is that if these patients had known risk factors for COVID-19, such as travel or exposure, they would have been tested for COVID-19. So what we're trying to look for is people who are falling outside that net, and so far we're finding almost none.
Sean?
But Dr. Williams, this is, as you discussed last week, this is not an RNA test. What is the sensitivity and specificity of this test? And also, I believe you explained last week that this sample size goes back to December 15th, correct? So the majority, it was 300 tests as of last week, so you've done 600, but the first 300, and these are people who come through with cold symptoms, common cold, or flu symptoms, correct?
Yes, let me take those two in order. In terms of the nature of the test, this is an RNA, or what's called a PCR test. It's the CDC test. So it's the same test that the CDC is using. That's the test that almost all labs in the country are using. If we do have any positives, we have a second World Health Organization listed test that we use to confirm those. So the test is extremely sensitive and extremely specific. We've been doing the surveillance going way back, but the ones that we've tested for COVID-19 start in February. We didn't find any in the month of February, so we've only found a very small number starting in March. And we're pretty much caught up through current testing. So the numbers I gave you are up through this week.
I think your concern was the sampling diluted by specimens long before anybody could have concerned about it, and the answer to that is no.
Yeah, this 950 is only from the middle of February, and the majority of those are from March.
Okay. Last question. This comes from Forever Media, a Cumberland, Maryland radio station. What is the timetable for a UPMC vaccine? Or put another way, when might the coronavirus no longer exist to be a threat?
So we have a number of scientists who are working on potential therapeutic and vaccine solutions. We're very excited about those opportunities. And in addition, diagnostic testing solutions as well. So our academic partnership is key to revolutionizing how we address and respond to the epidemic. That being said, as you've probably heard on a national level, a vaccine won't be available for use for some time, at least months, if not a year or more. We look forward to that opportunity. It will be helpful for the epidemic. But in the meantime, current focus is on therapeutics, including antibody therapeutics and pharmacologic therapeutics.
Okay. Well, thank you. That concludes the time we've allotted. Thank you for attending today. We plan to continue to hold these regular updates for the media for as long as it's necessary or as long as it's needed. In the meantime, reporters with questions are encouraged to contact our UPMC Media Relations Department at upmc.com/media, and please follow us on @UPMC News on Twitter for any updates. Thank you very much.
Thank you. Nice social distancing by our media colleagues there.